Hey everyone, welcome back to the channel. Today we're talking about something every nurse, doctor, paramedic, and honestly every healthcare student runs into sooner or later: blood pressure monitoring, but not just any blood pressure monitoring.
We're going deep into two terms that get thrown around a lot in hospitals, especially in ICUs and operating rooms: IBP and NIBP.
If you've ever looked at a patient monitor and seen these little abbreviations flashing next to numbers, and you weren't quite sure what they meant or why one machine uses a cuff while another one has wires going straight into the patient's wrist, this video is exactly for you. By the end, you'll know exactly what IBP and NIBP mean, how they work, when each one is used, and the real pros and cons of both. Let's get into it. What do IBP and NIBP actually stand for? Let's start simple. NIBP stands for non-invasive blood pressure. IBP stands for invasive blood pressure. The key word here, invasive versus non-invasive, tells you almost everything you need to know about the core difference between them. NIBP is the blood pressure measurement you're already familiar with. It's the one where a cuff wraps around your arm, inflates, gets nice and tight, and then slowly releases while the machine calculates your blood pressure. No needles, no wires going into your body, nothing invasive at all. It's quick, it's painless, and it's the standard method used in almost every clinic, doctor's office, and general hospital ward around the world. IBP, on the other hand, is a completely different approach. Instead of relying on an external cuff, IBP involves inserting a small catheter directly into an artery, most commonly the radial artery in the wrist, though sometimes the femoral artery in the groin or the dorsalis pedis in the foot. This catheter is connected to a pressure transducer, which is connected to the monitor, giving you a continuous real-time beat-to-beat reading of the patient's blood pressure. So right there, you can already see the fundamental difference. One is external and non-invasive, the other is internal and requires a procedure to set up. How each method actually works. Let's break down the mechanics a little more, because understanding how each one works really helps explain why they're used in different situations. With NIBP, the most common technique used by machines today is called oscillometry. The cuff inflates above the patient's systolic pressure, cutting off blood flow completely. Then, as it slowly deflates, the machine detects small oscillations or vibrations in the cuff pressure caused by the pulsing of blood starting to flow again through the artery. Using an algorithm, the machine calculates the systolic, diastolic, and mean arterial pressure from these oscillations. It's smart technology, but it's still an estimation based on external pressure changes. IBP works very differently. Since the catheter tip sits directly inside the artery, it's in direct contact with the blood itself. The pressure inside the artery pushes against a saline-filled line, which transmits that pressure to a transducer. The transducer converts this mechanical pressure into an electrical signal, and the monitor displays it as a continuous waveform, that iconic arterial line waveform you see on ICU monitors, rising and falling with every single heartbeat. This is a huge difference. NIBP gives you a snapshot, a reading every minute or every few minutes whenever the cuff cycles. IBP gives you a live, continuous, second-by-second picture of what's happening inside the patient's blood vessels. Accuracy, which one is more reliable? This is where things get really interesting, and it's honestly one of the biggest reasons IBP is considered the gold standard in critical care settings. NIBP is generally accurate for stable patients with normal blood flow and normal vessel elasticity, but it starts to lose accuracy in certain situations. For example, in patients with very low blood pressure, irregular heart rhythms like atrial fibrillation, obesity where cuff sizing becomes tricky, or conditions causing significant vasoconstriction. In these cases, the oscillometric method can either overestimate or underestimate the true blood pressure. IBP, because it's measuring pressure directly from inside the artery, is far more accurate and far more reliable, especially in unstable or critically ill patients. It doesn't rely on estimation algorithms. It's measuring the real physical pressure of blood pushing against the arterial wall in real time. That's why in ICUs, operating rooms during major surgery, And for patients on vasoactive medications where blood pressure needs to be tracked second by second, IBP is the preferred method. Continuous monitoring versus intermittent monitoring. Another major difference comes down to how often you're actually getting data. NIBP is intermittent by nature. Even on automatic settings, the cuff typically cycles every few minutes, maybe every 3 minutes, 5 minutes, or 15 minutes depending on how it's set. Between those readings, you genuinely don't know what's happening to the patient's blood pressure. If something changes suddenly, you might not catch it until the next cycle. IBP is continuous. There's no waiting. The waveform is live on the screen at all times, updating with every single heartbeat. If a patient starts crashing, if their pressure suddenly drops due to bleeding or a reaction to medication, the change shows up immediately on the monitor. This real-time feedback is absolutely critical in situations where seconds matter. Think major trauma, cardiac surgery, or patients on continuous infusions of powerful blood pressure medications, where each method is used in real practice. Let's talk practically about where you'll actually see these methods being used. NIBP is everywhere. It's used in general medical wards, outpatient clinics, during routine checkups, in ambulances, and for most stable hospitalized patients. It's the default method because it's fast, safe, and doesn't require any specialized training or invasive procedure. Any nurse can apply a cuff and get a reading within a minute. IBP is reserved for more specific, higher acuity situations. You'll typically see arterial lines in intensive care units during major surgeries, especially involving the heart, lungs, or brain, in patients who are hemodynamically unstable, and in anyone requiring frequent blood gas sampling, since the same arterial line can be used to draw blood without repeated needle sticks. It's also used for patients on medications that need tight beat-to-beat blood pressure control, like certain vasopressors or antihypertensive drips. Advantages and disadvantages of each. Let's quickly weigh the pros and cons, because neither method is universally better. They each serve a purpose. NIBP's biggest advantages are that it's non-invasive, quick, low risk, and doesn't require specialized skill to apply. The disadvantages are that it's less accurate in unstable patients, it's intermittent rather than continuous, and repeated cuff inflations over long periods can actually cause discomfort or even localized skin and nerve issues in some patients. IBP's biggest advantages are its accuracy and its continuous real-time nature, plus the added benefit of easy blood sampling. But the disadvantages are real too. It requires an invasive procedure to insert the arterial line, which carries risks like infection, bleeding, or arterial damage. It also requires specialized training to insert and maintain properly, and it needs constant monitoring to make sure the line doesn't become dislodged, kinked, or infected. Wrapping it up. So, to sum everything up, NIBP is your everyday, non-invasive, cuff-based blood pressure measurement, quick, safe, and widely used, but intermittent and less precise in critical situations. IBP is the invasive catheter-based method that gives you continuous, highly accurate, real-time blood pressure readings directly from inside the artery, the gold standard for critically ill patients, but with added risks and the need for specialized care. Understanding when and why each method is used isn't just academic knowledge, it genuinely helps you understand patient care on a deeper level. Whether you're a nursing student, a paramedic, a doctor in training, or just someone curious about how hospital monitors actually work. If this video helped clear things up for you, drop a like, subscribe for more medical explainer content, and let me know in the comments if you'd like a follow-up video breaking down how to actually read and interpret an arterial line waveform. Thanks for watching, and I'll see you in the next one.